So feel free to interrupt as we go with any questions. Let's start with the elbow. And let's see. I want to make sure that I can. Am I good to go? So a few disclosures. I'm a consultant for BioClinica, book royalties from Elsevier, a grant from American Institute of Ultrasound Medicine, research equipment from Harvest Technologies. So we've talked about the sonographic techniques. I'm going to briefly go through it again, just very quickly, because a little redundancy I think is good. Then we're going to move on to the pathologic examples. So as I mentioned, if you put the transducer in this area, the brachial artery is a great landmark. The biceps is just lateral to it. The median nerve is just medial to it. Here's the brachioradialis over here. Now if we look posterior, remember that I connected the lines, the dots between the medial epicondyle olecranon process. This is where we see the ulnar nerve. What I want to point out with this drawing is this is the enclosed space between the two heads of the flexor carpi ulnaris, or the true cubital tunnel. But because entrapment will cause swelling proximal, we tend to measure things up here where it's maximally swollen, but the true tunnel, the cubital tunnel, is where this traverses between the two heads of this muscle tendon. So as you saw, I tend to approach every elbow the same as a radiologist, just like I'd read an MRI in the same sequence, and I try to get as much information as I can. I start, just like I did here, anterior, medial, lateral, then posterior. Now, in a busy clinical practice, or if you're a clinician, you could target your exam, of course, to where the money is, but make sure you consider a number of items in that quadrant as your focused exam. There is a benefit of a comprehensive exam. One is that you can deal with referred pain. The second thing is that you become very efficient at the exam. And if you do every exam the same way, you don't go back in the room and think, oh, I forgot to look at this, because you do it on every single case. The last point I want to make is if you're trying to understand subtle pathology, the only way to get used to that is to understand normal anatomy. So if someone is looking for an ulnar collateral ligament tear, that shouldn't be the first patient I've ever examined for the UCL. I want to look at the UCL on many, many people, even without pain there. Because if you do a comprehensive exam and you're scanning areas that aren't abnormal, it really is not that, it's not that slow to do when it's really normal. It can be very quick. More